on digital innovation in health. Really topical and interesting, interesting area in which we need to constantly work at bringing together digital technology experts and health experts to explore the way in which digital health might help us resolve some of the health service delivery challenges we have across Northern Australia. So I'll start by acknowledging that I'm coming to you from Bindal and Walgorooka country here in Garambulbara or Townsville, and paying my respects to elders past, present and future. This is one of the TAAHC webinar series. Most of you will probably know about these. TAAHC is the academic health centre accredited by the NHMLRC that brings together the 5 North Queensland hospital and health services with Quake and the Primary Health Network and JCU, and have research themes around service delivery, innovative health workforce models and non-communicable diseases and infectious diseases. So these webinar series are an opportunity to hear about some of the research that's going on across the region, to ask questions, to interact, to form some communities across fields and regions a little bit. So we encourage you to be a little bit interactive. In terms of housekeeping, if while we're going, you can please mute your microphones and turn your cameras off. We do want them to be a little bit interactive, so encourage questions. You can either put them in the chat, or we'll have a question and answer session after both presentations, and I will ask for any burning questions after each of the presentations as well. So you can raise your hand and come off mute and have your moment in the sun, and I'd encourage that. So we're really lucky today to have a couple of really interesting speakers. I'll introduce myself first. I'm Sarah Larkins. I'm a GP Health Systems researcher, Professor of Health System Strengthening at James Cook University. I sit in the College of Medicine and Dentistry, and I'm also convener of the TAAHC Clinical Leadership Group across regions. I'm pretty passionate about how we can make the health system work better and more equitably for people in rural and remote areas. We've got 2 fantastic speakers, Stephanie Baker and Finley Sherwood. I'll introduce, you can see their areas and their pictures there on the screen, and I'll introduce them more fully just before their presentation, but would like to thank them very much for coming and talking to us today. The structure is, I'm just going to talk for a minute or 2 from now, and then we'll give each of Stephanie and Finley 15 minutes or so to talk to us about their areas of work, and then have some questions and answers to discuss it. So these presentations are kind of part of the Northern Australian Regional Digital Health Collaborative, which is a collaboration between JCU and those other partners you can see there, the CRC, Northern Australia, TAAHC, the Primary Health Network, Optus, and the eHealth Research Centre from CSIRO. And it's funded by the Australian Government DEACE under the SURF program. Just to start you thinking about this, there's been an absolute proliferation of digital health and ways that we can use that right across the region. And we know we've got service delivery challenges across Northern Australia. And it's quite possible that many of these digital health initiatives are part of the solution, but the challenge is bringing health people and digital technology experts together and trying to get us to talk the same language a little bit about what we're talking about, to understand how all these technologies can be used to help address some of the healthcare needs. And you can see from the slide there a whole lot of examples about how we might be able to use things, but thinking about enormous big data sets that are coming out of electronic medical records, potentially out of biological data, electronic records, and how we can use that in terms of remote monitoring, in terms of predicting deterioration, in terms of lifestyle management, in terms of streamlining patient flow, and indeed in planning services and workforce deployment and how we can do that better. So the Northern Australian Regional Digital Health Platform or Collaborative, it has 5 big programs of work. Both of the projects we're going to hear about today are funded as seed projects under the Digital Tech Incubation and Development stream, but also have crossover into big data and planning and integration. And so you can see that there's quite a lot of options going on there. So I'm going to stop mucking around and talking here and hand over to the real stars of the show, who are Stephanie and Finlay. I'll start off with Stephanie. So Dr. Stephanie Baker is a lecturer with Electronic Systems and Internet of Things engineering team at JCU based in Cairns. She's got a PhD in biomed and software engineering and a Bachelor of Engineering in Computer Systems Engineering, and has been really thinking about and playing around with how we can use responsible artificial intelligence to solve significant problems in a range of fields, and most recently doing quite a lot of that work in the healthcare field, and particularly in aged care. So Stephanie is going to talk about her work in remote monitoring in aged care and how that might be applicable in rural and remote Australia. So over to you, Stephanie. Thanks.
Thanks, Sarah. I'll share my screen, so let me know if you can't see it in a few seconds. Has everyone got that there now?
Yep, there it is.
Cool. Great. So yeah, I think that introduction was fairly comprehensive. Thank you, Sarah. I would also like to acknowledge the traditional owners of the land on which I'm operating. So I'm in the Cairns region. And so that's the Gamoy Walubara Yidinji people, the Jabberkai people, and the Irukandji people. And I pay my respects to the elders past, present, and emerging. So today I'm going to be talking about, as Sarah said, primarily my research in the artificial intelligence and Internet of Things space. But I also want to talk a little bit about just what's generally happening in this space, because there's a lot of cool things going on around the world. So yeah, my background is computer systems engineering, but my focus has always been using these technologies primarily for healthcare, and with a particular focus on our rural and remote regions, particularly in Northern Australia. So today I'm going to work my way up this pyramid through this presentation. So I'm going to start off with a little bit about artificial intelligence and Internet of Things and what they are, and climb up to how we can bring them together to support rural healthcare. So the first thing I want to say is that despite what recent media might have you believe, artificial intelligence is actually pretty stupid. So artificial intelligence, or AI, is just any system that seeks to mimic how humans process and interpret data. But they're really one-trick ponies. So they're taught how to recognize patterns and generate outputs for a particular type of data, but that's the only type of data they know how to handle. So you can't ask ChatGPT to identify a broken bone in an X-ray, because it only knows how to generate text based on text, and in some cases, simple images. So we don't need to worry about Skynet or Ultron just yet. So while people are smarter than AI, we do have one disadvantage, and that is that it takes us a long time to look at massive amounts of data. That's one area where AI is better than us, because it can look at large amounts of data all at once, and thus it can pick up patterns that we can't necessarily see. Once it's finished learning, and once it's finished its learning stage, it can apply that knowledge to new data and do things like make predictions, or it can generate similar patterns to what it's seen in the past. A key challenge, though, is that AI, while it's good at looking at massive amounts of data, actually needs that massive amount of data to succeed in the first place. So back to the ChatGPT example, it was trained on over 570 gigabytes of text data, which is roughly equivalent to 570,000 ebooks, which is probably a few more than you had to read to get a grasp on the English language. And it's still not particularly good at it compared to a lot of us. So the fact that AI needs to learn from large amounts of data means that we first need that large amounts of data. And in the world of Internet of Things technology, or IoT, we actually have a problem that turns out to be pretty complementary: far too much data. So Internet of Things, or IoT devices, are just anything that's connected to each other, networked together in some way. And in healthcare, that can include a wide range of things. So that can include wearables, it can include non-contact sensors, more conventional things like blood pressure, sphygmomanometers, And it can also even include things like coffee machines and beds. So in some recent studies, there's been some research around monitoring how people interact with their conventional household items to try and track things like the progression of dementia. So currently there's about 7 billion IoT devices in operation, and these collectively gather more data in a single day than we had data in existence up to 2003. So 20 years ago, there was less data than these devices are collecting in a day. We mere mortals can't make sense of that much data, but AI can at least try. So because AI needs a lot of data, IoT produces a lot of data, there's a growing body of research drawing these two areas together. And I'm going to broadly talk about these today in the context of healthcare in these 4 categories. So I'm going to talk mostly about health monitoring, diagnosis, prognosis, and disease discovery. So first up, we have health monitoring, and this is a space that I've spent a fair bit of time, primarily focuses on where AI and IoT can be used to monitor a health condition or a particular parameter. In my own work, I've mainly focused on vital signs, monitoring blood pressure and respiratory rate using photoplethysmogram and electrocardiogram sensors. So as you all know, continuous measurement of blood pressure that's truly continuous and non-invasive is still something that we haven't achieved. But if we could try to use AI to measure blood pressure from PPG and ECG sensors, then we actually could have something that's truly continuous. So what we did is, in our work, we trained an AI model to calculate blood pressure using 5-second segments of PPG and ECG waveforms. So we fed those raw waveforms straight in. And the AI model looked like this. I'll come back to that in a second. And the data we collected all came from the MIMIC waveform database, which was is an open access database of critical care data from the States. So this slide mentions that the AI model had 2 parts. It has a convolutional neural network stage and a long short-term memory network stage. And without getting into the math, I'll just give a bit of context on what those actually do. So convolutional neural networks, or CNNs, are the ones that are really commonly used in computer vision tasks that look to classify some sort of image. And the reason for that is that they're really good at finding features that are important within an image. The same logic applies with waveforms. They can sweep through a waveform one chunk at a time and pick out the features that are important to a particular problem. So that's what the convolutional neural network stage does. And then it passes it on to the long short-term memory network, or the LSTM stage. And this stage is really good at finding relationships between features. So again, they sweep through a waveform, and now we've got those extracted features. It looks at what the important relationships might be between those features. Put the 2 together and we get a powerful system that both finds the features and the important relationships between those features. And this model that we developed it worked really well. So it showed a really strong level of agreement with gold standard intra-arterial monitoring without the need for needles. So that's a pretty big plus. And it also did really well compared to the literature and met all of the industry standards for blood pressure monitoring devices. So the one catch with this is it was only critical care data at this point. And so we're looking at now taking this further and training a model to do more general population, which is part of the project that has been funded by the TAAHC grant. So I'll talk a little bit more about that later. But this was kind of stage 1 in our pathway to doing that. Outside of my research group, so we've mostly focused on vital signs, but that's not the only monitoring that's happening out there. Some other research groups have looked at things like monitoring of mental alertness, for seizures, monitoring for wandering behavior. And there's also been some works on non-contact measurement of vital signs using things like conventional cameras. So I've got a bit of a list of the papers there. If anyone's interested in reading more into this stuff, I'm happy to share these slides so you can grab all of those and dig deeper. So our next major category where AI and IoT have found a lot of use in healthcare is diagnosis. This isn't actually an area I've spent too much time in just yet. I am starting up a project with the Townsville University Hospital's neonatal ICU on diagnosing and ideally predicting acute kidney injury in preterm neonates that are there. But that's still early days. However, there's plenty of other research groups that are looking at diagnosis problems with AI and IoT. Some that are listed here include diagnosing malaria, diabetes, dyslexia, and anxiety, all using very low-cost IoT sensors that make them a bit more accessible in rural and remote areas. So that's, again, a bit of a list of papers. Happy to share those if anyone wants to dig deeper. But for now, moving on to the next category of prognosis. So I have spent a fair bit of time in this space, mostly on predicting mortality in intensive care settings. So my most recent work was focused specifically on predicting mortality outcomes in neonatal ICU. So we developed this thing that we called the Neonatal Artificial Intelligence Mortality Score, or NAMES for short. And it's again a CNN LSTM model due to the same benefits I mentioned before. It can find the important features and find the relationships between it. Except this time the inputs were a bit different. We actually took some statistics about variation in heart rate and respiratory rate over a 12-hour period, because we didn't have continuous waveforms. We only had discrete like chart events for this data. We also put in some fundamental demographics as well. And we were looking to predict mortality outcomes within 3 days, 7 days, and 14 days. And all of the models worked pretty well. So this is the OROC and ORPROC curves, and they indicate, if you're not familiar with these metrics, they just indicate the ability of a model to distinguish between two cases. The more area under the curve there is, the better. As you can see, particularly for the blue one, which was our 3-day model, there's a lot of area underneath that curve. So that is a good sign. So yeah, our 3-day model outperformed all of the schemes in the literature. The 7-day model also worked pretty well. 14 days started to fall down a bit, but that was sort of expected. And the other thing worth noting is the features that we used were things that could be obtained through low-cost IoT sensors. So heart rate, respiratory rate, and a couple of fundamental demographics that could be taken down at the start. That's in contrast to the literature, where most of it was laboratory test results, the treatments they'd received in the past, extensive medical histories, that sort of thing. So it required, a lot of the works in the literature required a lot more clinician time before it actually could be utilized. Outside of our group, there's also lots of other cool things happening in prognosis. So there's research groups that have looked to predict post-stroke and neurodevelopmental outcomes. And there's also works that have looked at predicting cancer recurrence for people that are in remission. So all of these things, if we know what the risks are, then it can help to guide treatment decisions and care plans. So that's the main goal here. So that brings me to my last category, which is disease discovery. So this category includes things like discovering markers that are associated with particular diseases. And it overlaps quite heavily with explainable AI tools, which are tools that are used to make AIs actually explain and justify why they made a decision. That's sort of an adjacent topic that I could also talk about all day, but I'll try to keep it brief given that we don't have that much time. In my own work, I've primarily used an explainable AI tool known as Shapley additive values. And these work by removing one feature from the model at a time and seeing how much it affects its ability to make an accurate prediction. So they generate a few different types of plots. This one it's my preferred way of looking at the data. So on these plots, the red dots indicate a high value for a particular thing. So I'll grab there's my little laser. There we go. So here for gestational age, you can see high gestational ages were in red and the lower gestational ages were in blue. And same with like the heart rate, high heart rate in red, low heart rate in blue. If the dots are on the left, then that means that they're connected with non-mortality. If they're on the right, then it means that they're connected with mortality. So why does this matter? Well, the first thing it does is it gives us some confidence that the model might actually be working. So in this case, the models, the 3-day and the 7-day models pick gestational age as the most important feature. And we already know that. So in the literature, it's well established that low gestational age is linked with mortality outcomes. So that's reflected in what the AI model used to make its decisions. So that gives us confidence that it's working. And it also gives us some interesting avenues to explore in terms of the relationship between respiratory health and outcomes, because that was something that was highlighted as important by the different models. I'm not sure how much we know about that at this stage, but it could be something worth exploring further. So this is one use of explainable AI. These graphs sort of show how the AI model performs across all predictions that it makes, but it can also be used for individual predictions. So in this example here, the top one indicates how the AI made a non-mortality prediction, and the bottom one's a mortality prediction. And you can see that the AI has sort of said, these are all the things that pushed me towards making a mortality prediction, and most of those are in red pushing towards that side. But there are still a couple in blue pushing back the other way. So we can see in these two cases that the AI was quite confident about its decision, and it tells you why it was confident. But in a scenario where it's less confident, you'd see more like 50-50 red and blue. And that would also help us to understand whether the AI is making reasonable decisions, because if it's not confident, then we perhaps know that we need to look into it further and not necessarily trust it implicitly. So that's another way that it can be really useful in, well, not just in healthcare, but certainly as one of the applications of it. So there is also plenty of other researchers working in this space as well. In terms of biomarker discovery, there's been works looking at identifying parameters associated with things ranging from chronic kidney disease through to PTSD. There's also works that have looked at highlighting individual predictions. So this figure here comes from one of the references, and they looked at highlighting regions of an ECG that were relevant to classification of parts of a heartbeat as well as arrhythmias overall. So yeah, I think this is a really exciting field of research, and it's one that's moving quite rapidly. And like I said, I'm happy to talk about it all day if anyone wants to ask more about it towards the end. So now we've reached the point of the talk where I'm going to bring all of that together. So why does all this stuff that I've just spoken about for the last 10 minutes actually matter for rural healthcare in particular? Well, I would say it's perhaps more important for rural areas than it is for just about anywhere else. The reason being that IoT can really help to support monitoring and telehealth for patients in their home or in their primary care facilities who are living a really long way from specialist services. Meanwhile, AI can serve as the brains behind the IoT devices to make sure they're making accurate decisions and measurements and everything else. So that really helps to provide people with higher quality care closer to home, and can help to link them to their specialists, even if, maybe even their primary care provider is a long way away. So the main reason I was asked to give this talk today is because, as Sarah mentioned, I'm currently working on a project that ties AI and IoT together for rural healthcare. It was funded by the TAAHC grant, and we're looking at developing a smart home prototype that combines non-contact and wearable IoT sensors to provide comprehensive monitoring of both health and activity. So we're going to be using AI as the brains behind all of the processing that we do. The main wearable platform that we're using is called the Empatica Embrace Plus, and it's a medical research wearable that we are using to get PPG signals and sweat signals, as well as monitoring movement with accelerometers. Accelerometers are the same things that like your Fitbit and your Garmin use to do the step counting. We were hoping to do ECG as well, but unfortunately they stopped making the add-on for ECG of this one, so we're a bit limited to just the PPG this time, but hopefully we'll still be able to develop some algorithms for blood pressure and respiratory rate monitoring that work well on the general population. And we'll also be combining our accelerometer data with non-contact activity monitoring technology. So we're looking at using millimeter wave technology, and that works in a similar way to Wi-Fi. So it sends out radio waves, and those radio waves hit the person and they bounce back, and measuring those reflections can tell us what that person is doing, whether they're sitting, standing, walking around, reaching for something in a cupboard. So we're hoping to be able to classify those activities based on the signals that bounce back in combination with the accelerometer data from the wrist-worn devices. So the main benefit of millimeter wave over ways that this is done currently is that it's quite privacy preserving, and it gives us a lot of data. So you can't actually see the person or anything else, but it gives quite rich information about their movements inside of a building. So the key goals of this project really fit into the AI IoT architecture for healthcare that I've been talking about today. In terms of basic monitoring, we're mostly looking at vital signs and behavior, with a particular interest on blood pressure, because that's still the one that I think is the least solved. In terms of diagnosis, in the short term, we're mostly looking to notify carers if there's anything outside of the normal ranges for behavioral vital signs for a particular person. And we're also looking at detecting stress and fatigue. So that's going to be partially with the sweat sensing that we're doing as well. Longer term, we're hoping that the system can be used to support diagnosis of more complex conditions, including dementia and Parkinson's disease. And we're hoping that in the prognosis sense, we'll also be able to use the system to support assessment of the way that the disease is progressing and response to treatment, stuff like that. We're also hoping that long term, we'll be able to help support rehabilitation after events like a stroke by monitoring the progress of someone who's experienced an event like that. Lastly, in terms of the disease discovery explainability domain, in the short term, we're mostly hoping to use tools similar to what I discussed earlier to actually clarify how AI systems are making decisions so that patients and their care team can actually trust the AI system or not trust it as appropriate. And in the longer term, we're hoping that the data we'll be collecting through the course of using this system will also help contribute to a better understanding of complex conditions like dementia and Parkinson's. So that's all I have for today. Thank you for listening to me talk for the last 15 minutes. I hope you found that interesting. I do have some more information about me here if you'd like to get in touch. And as a final dash of shameless self-promotion, I actually wrote an article where we reviewed the literature on AI and IoT for healthcare just a few months ago, and that's out now in one of the top electrical engineering journals. So if you'd like to read that, there's also a QR code there. Thanks.
Fabulous, thank you, Stephanie. That was really interesting. Really interesting presentation, and a sort of seamless integration of all the different ways in which the wearable and Internet of Things and artificial AI, big data capabilities can come together to help with healthcare. So look, welcome to the new future of what might be there to supplement healthcare. So does anyone have any burning questions for Stephanie now? Otherwise, we'll go on to Finley and have Q&A afterwards. I don't see any hands up right now. No, and I think if you're able to send those slides on to Ray or just the TAAHC email, TAAHC@JCU, then that would be great, and we can put a link to the QR codes, or so that people can look up those articles, because there was a lot there, and it's just interesting seeing this review. There's a lot of health people that would be really interested in that, but they would not possibly find it in that journal. So again, how do we talk to each other across discipline silos?
Yeah, this has actually been a challenge for me in terms of publishing, because there's not actually too many journals that do interdisciplinary engineering and health. I often find the engineering journals don't want me because it's not engineering enough, and the health journals don't want me because it's not health enough.
Yeah, exactly. So getting joint authorship, I think, is important.
Yeah.
Okay, thank you. So if you can yes, so Bex just commented she appreciates your accessible explanations of complex concepts, and I think you're developing real skills in that area of translating those, and it's very valuable. There's not too many people that can do it. So thank you very much. So we're going to go over to Finley now. So Finley's a graduate from JCU with a bachelor's degree in IT. He's a research assistant at College of Science and Engineering, with a background in web and app development, and currently a member of the team that's developing the CKD-free mobile app. And so this app aims to provide effective early detection and prevention strategies for chronic kidney disease patients. So Paul Finley was dobbed into this presentation. So thank you very much for stepping up to the plate and taking it on. And over to you to tell us all about how the CKD-free app is going on, and this is clearly a different purpose of using digital technologies, more patient-facing. Yeah, thanks, Finley. I'll leave you to share.
I should probably open up my screen share as well. Get that going there. If I full screen that, can you see that the slides there?
Yeah, that's perfect, Finley.
Yep, that's working. Okay, cool. Yeah, so as Sarah was saying, I've kind of like jumped into this last minute, so hopefully I can give a good presentation. A bit nervous after Stephanie's, that one was really good. But anyway, yeah, so I'm Finley, and so I've been working on CKD-free, which is a mobile app and dashboard, essentially for managing early chronic kidney disease. So I've been working on this with Daniel McKenzie, who's just behind the screen here with me now. So we've been working with Osmond on this project for the past couple months now. So let's just get into it, I guess. So the aim of this project was essentially to develop a mobile app which can detect, it can early detect individuals who are at risk of deterioration of renal function and needing intervention and all that. And so the main focus of this is on Indigenous patients, particularly in remote and regional areas. And so in addition to this, we're also working on making a web dashboard that can be usable by both clinicians and researchers, because we're also collecting quite a lot of data here that can be very useful for other things and all that, and also just having the real-time access to that data rather than getting a logbook that you have to wait a month or two to get, which was something Sarah was mentioning yesterday. Just ends up with easier monitoring and so this is the reason why we were mainly focusing on Indigenous Australians. As you can see by these charts here, Indigenous Australians are getting almost 7 times higher rates of kidney replacement therapy than non-Indigenous Australians. Let me just see, can I, here we are. So yeah, kidney failure is rarest in the inner regional areas. So in cities and all that, it's much lower, and it's the highest in these remote areas. So this shows a correlation between how remote someone lives and how likely they are to undergo kidney failure. And so the assumption with this is that it's the inability to easily access hospitals and clinical professional resources. And so yeah, so the most common type of kidney disease in these patients is diabetic nephropathy. So the rate of this in Indigenous Australians is 15 times higher than that of non-Indigenous. So you can see by that chart, 45%. It's absolutely massive. And so the behavioral risk factors linked to chronic kidney disease can also include other things like smoking, poor diet, insufficient physical activity, excessive alcohol consumption, all these kinds of things that are also commonly related to diabetes, which is, why diabetic nephropathy is such a big problem here. So the approach that we've took with this is initially going through a systematic literature review on the existing studies to try and get a better understanding of where we're currently at with the research. And so there are a couple resources that were particularly interesting, like CKD Go, which I'll talk about just in a moment, which is a kind of a similar app, but with a different focus. And so there's, lots of papers and systems that are kind of doing similar stuff, but particularly not so much in the rural areas. It's much more focused on in a city, or like the capabilities that you would get from being in a city. So you can see these screenshots here. This is that CKD Go app. So I believe this is made by Kidney Health Australia. And so the existing study, so there's this one, and then there's also another app called Success CKD, and a couple online form kind of versions of these that you can access. But generally what they're using is stuff that you can only get through blood tests and urine tests, like the EGFR and ACR, blood pressure, all of that sort of stuff. So I'm not sure if you can actually see my cursor here. That might not be possible, but okay. On the leftmost screenshot there, you can see they have these like sliding bars where you can select your ACR and EGFR and all that. And if you live in a rural area, you might not know this whatsoever. If you haven't had one of these tests done, you just won't know these values. And even if you have had that test done, it's difficult to make any conclusions based on this, because the response that you get from it is not very informative. It's not helpful for someone who isn't already well versed in this kind of information. So other important risk factors, like the ones I was mentioning earlier relating to diabetes, like the exercise, alcohol consumption, smoking, all of that also isn't used in any of these apps. So they pretty much just rely on this ACR, EGFR, these like clinical results. And in addition to this, the app design is not the best for these ones. So they're not goal driven and they're not particularly user friendly. So you have stuff like this one. You can see they have this handbook that's full of useful kidney disease information, but it's difficult to access, difficult to read. It doesn't really give people a purpose to read it outside of their own like desire to learn more. So that makes it much more difficult for people to actually learn and like be motivated to be using the app and understanding how to use it. So that's where we've come in with CKD Free. So you can see some screenshots there of our mock-up, but what I can actually do here is just tab out of this, and I've got a little demo going here. So this is, I've just got my phone streaming to my computer here. So you should be able to see that, right? You can see in the phone screen with the app open.
We've got your login.
Yep, that's working. Okay, cool. Just wanted to make sure, but in case I didn't start working through it, but then nothing. Okay. So yeah, so this is the homepage that you come to, and so obviously you need to log in. So for the sake of the demo, I'm just going to make a demo account here. So just your very standard login system. So we log in, and so the first thing it does is it asks you to set up your account. So they'll be asking some general information about yourself. We keep all of this data private, anonymized. So this is used in the UI and all that kind of stuff, but we won't be able to actually see it ourselves unless there's like been express consent given by the user. So that's to kind of ensure that it's, we're not collecting too much like private data unnecessarily and whatnot. So I'll just enter in this making an account as if it's myself. So asking stuff like, date of birth, sex, if I'm Aboriginal or Torres Strait Islander, because as we saw before there's some very uneven data there. Height, and then there's all these questions like kidney disease or a history of kidney disease, diabetes, cardiovascular disease, high blood pressure. These are all the kinds of things that we want to be collecting information on that there isn't a ton of data on at the moment. So just continue through, just answering all the questions, and here we are. And so then we can submit, and now we're in the app. So this is what someone would see if they were to just log in, if they were to just open up the app on any random day. You wouldn't be taken through that whole sign up page and all that. You just get put right here. And so the first thing that you'll notice probably is this big streak thing, as we call it. So this has been inspired by Duolingo, which is if you don't know, a app that's used to teach you languages. And so it encourages you to do daily lessons by giving you this streak where you have to come back every day and do a lesson every day to keep your streak going. So we've taken that same kind of concept, but instead we're using it to complete morning reviews. So this is the kind of data that we want to be collecting that isn't accessible easily at the moment. Like there isn't the data sets out there. So these are some more of these kinds of things that we want to look further into. So we have stuff like how much alcohol has been drunk. So let's just say I had 4 to 6 gin. Let's say I'm a smoker at 6 to 10 and put in 83 kilos. And so then you can rate your diet on a daily basis and all of that as well here. So this is to get a more granular idea of where people are at. And then also how much exercise they've done. One thing that we were asked by our clinicians to add was just a reminder to take medication. So we just chucked that in there as well, just as a handy reminder. But when we submit that, you can see there are a couple of factors here from what I'd entered that it thinks mean that I'm potentially at risk of developing CKD. So it tells us that very clearly, and then it also explains the problem that we've entered, and something that we can do to fix it. So, reported 6 to 10 smokes a day. So reducing smoking will help reduce your risk of developing kidney disease. And so once that's done, you can see we've now got the start of our streak. We've just started it. And now we can't submit a new one because these are only intended to be done once a day. And so this will encourage people to come back and then continue to use the app, keeping the clinicians updated with the state of their patients, and providing valuable regular data for each person. So you get a really good set of data as a result of that. You can see in an attempt to try and encourage some more education, we've got it here to also give just some useful tips. Processed food high in sodium can increase your risks, that kind of stuff. So this is kind of our effort to help educate more easily. So in addition to this, we can also submit the clinical results. So this is the same things that the other apps are doing. This is like our way of doing that. So you can submit stuff like your eGFR. So let's say you have a 70 and then the ACR is 5. We also take stuff like blood pressure and blood glucose. We can leave these blank because this, you only need to submit what it is you've actually got tested. So imagine I've done this today. We can enter in that data and submit that. And you can see it gives us this heat map where it also actually plots where you currently are on it. So you can see this dot, it might actually be a bit too small for you to see on the stream. But you can see that's kind of showing very clearly that we're in this yellow section. So we're very close to the green, fairly healthy scenario, but not the best. But then in addition to that, if I submit another one and say we've deteriorated a bunch, we're down to 30 and we've got 100 for ACR. Let's say for whatever reason this happened the following day, we submit that. It just takes a moment. We've got it set up so that at the moment, just for testing, we're using some slow services, but then we'll be able to scale them up, or it might just not work, which I guess the demo, oh no, here we are, all good. But yeah, you can see here now we've had the movement in where we are, and we can kind of see over time how we've progressed. So in this case, we've deteriorated and we're in a worse section. And so that can just track over time and give like a good visual representation of that for the actual user themselves. This last one, just to show, that's just so that you can update this stuff if you need. But that's pretty much where the app is at the moment. So providing as much value as we can reasonably provide. We don't want to be making actual predictions on the likelihood of someone's risk. So we just say, you are potentially at risk, or we can't determine your risk just because we don't currently have that clinical proof for that yet. So this is kind of used in order to collect that data to then develop the models and progress from there. So if I return back to the presentation now, you can also see we've got this mock-up for the dashboard. So this is in production at the moment. So this isn't, we're not ready to demo this, but you can see essentially this is the researcher and clinician side of things. So this is, you can see we've got heaps of data on each person, lots of like useful visualizations and all that kind of stuff. The kind of stuff that would be very useful for these people. So this is, I guess, a kind of dot point explanation of our service. So yeah, we collect the data on the important risk factors related to diabetes, all that kind of stuff. This will then allow us to more accurately understand patients and those and detect, use that data to build machine learning, deep learning models to detect the early signs of CKD. And our app is much more friendly and goal-driven. So it's meant to be much easier to use, especially if someone's not as familiar with technology, if they're living in a rural area and they're not so used to using the mobile apps and all that. We want to make that as streamlined, as easy as possible. And we're working with clinicians like Christian and Conrad to try and refine the app and implement things that are useful from their end, because I'm an IT graduate. I don't know all the details of all the health side of things. So they've been very helpful in giving us that kind of more professional side of things there. And so if you want to give it a try yourself, we've actually got a web version of the app up there, app.ckdfree.com. So if at any point you just want to kind of have a closer look at what we've been working on, we always keep that up to date. And apart from that, thank you for listening. If you have any questions, I should be able to try to respond to them. But yeah, thank you.
Thank you very much, Finley. So if you perhaps just unshare your screen, hopefully, again, if you want to share that, we can put it up so it's available for people.
Yep.
But again, developing something that's more in terms of health promotion and prevention for people to be able to assess their own risk and make changes to their own behaviour, and then also share that information with a treating clinician. I think, as we talked about yesterday, then sharing it with a researcher is there's a whole lot of extra approvals and consents and privacy issues to consider, but really useful. And so discussion has come in clinician roundtables about some of the needs that people had, and some of these projects have come out of that, and now we're trying to refine them and adjust the language and so on to make them really applicable. So great. I'm going to hand over to for questions from anyone in the audience, if you've got any. And right. Straight over to you.
I think that were great presentations, and I feel indebted to Stephanie for helping me understand that AI is a one-trick pony, and so I won't worry too much about it, I suppose, at this stage of the game. Finlay, my first question is for you. I think I'm really into the app. Looks really interesting. What I was interested in, particularly, I work with a lot of consumers in health and stuff like that. And when you showed me that after entering, your scary data from the day before, or the morning of, talking about the day before, it came up with the message, you're at risk of CKD. And I'm wondering about, if you are truthful and write those bits of information on a daily basis, does that message come up on a daily basis? Because if it does, I wonder if people will habituate to your scary message and it becomes less scary and they don't really care anymore. So that's number one. What do you think about that? And number two is, in your project, are you going to ask for user feedback? What was it like for them to use your CKD-free app?
Regarding the message that it says, that is something that I have thought about before, is like how big of a problem that could potentially be if they're seeing that every day. That's one of those kinds of things that we can definitely look into and look at changing quite easily. But we haven't had a ton of time to work on this project, so some of those kinds of more detail, like specific things, we haven't been able to refine as much as we would have liked. The project, we got cut off at the start and then also cut off at the end, so we'd lost like a good couple months. But we do have another like 2 months or so to continue work on these things, and we can definitely look at fixing that. What was the other one?
I was just wondering if you had any opportunity to ask the users of your app, not the necessarily the
Ah.
clinicians, but the people who are using your app.
Yes.
I wonder if you have embedded that into your evaluation.
So we're about to begin some pilot testing where we will be getting some user feedback. I thought that we had mentioned that in the PowerPoint, but I realize now I didn't actually say anything about that. I think it might have had a point that I just kind of glossed over, but yes, we're actually aiming to have the app published for the testing literally like today or tomorrow. And then from there, Osman's, I believe he's purchased a couple tablets to actually give to some people in order to test the app. So yeah, we don't have feedback built into the app itself, but we're absolutely going through with that pilot testing over the coming month or two.
I'm just looking at who's here, and there are people there are some rural and remote clinicians on the line here who might have really interesting perspectives, and I'd love to hear from them if they're able to come off the mute. But otherwise, I can ask some more questions. Look, I'm just really interested in sort of this process of getting from wearables. So where the whole notion of accustoming people to wearing wearables, having their data reported and having action coming from that. It's a very big sort of interpersonal shift that has to occur in people's relationships with machines and data. And I'm just wondering, I guess it's probably more to Stephanie, this one, but wondering what you think about how we progress that and getting information to a carer or a clinician or someone else who might need to know about deterioration and what the next steps might be.
Yeah, so I think that's a big challenge because partially, every GP clinic just about is using a different platform for collecting data in the first place. I know even like myself personally going to the doctor, they've changed their platform like 3 times in the last 2 years. So I think actually having that in a standardized format where we can pass the information obtained through wearables and AI being collected in some way that's consistent, that's sort of the first big challenge. In terms of getting people accustomed to wearing wearables, I'd actually like to study what people's feelings are on that right now, because entirely anecdotally, I know a lot of people who, perhaps don't fit into the conventional Gen Z category, but, like my grandparents, they wear wearables all of the time. So I'd be interested to see what the actual numbers are on adoption and if there's, particular groups of people who are less I guess, accepting of them right now and what we can do to shift those attitudes. So I think we need to understand what the limitations, what the barriers to adoption are so that we can address the barriers to adoption first.
Yeah. I mean, anecdotally, the great advantage of these things is that you don't have to be particularly digitally literate or literate to use them. Anecdotally, I know quite a few people who have got their elderly parents, frail parents, Apple Watches or whatever, so that they can get the falls detection and can follow up on that. So I think there's some adaptation, but how do we take it the next step of incorporating it as part of healthcare?
Yeah, and I think even devices, right? Like having some sort of consistency across devices is going to be challenging, because even if we get this stuff working with PBGs for measuring blood pressure, there's obviously a lot of steps between that and actually getting it to be rolled out on some sort of device that people are using every day. So there are certainly, I think it's a long pathway, but I think there's ways we can make progress in each of those areas.
Have you had any discussions with people at the PHN yet about this sort of work? And because I can link you up with that in terms of integrating into primary care and contact with primary care teams.
No, so I haven't yet. I mean, at this stage, we're still in the sort of phase where we're using retrospective data. So we're collecting the data first and building AI models based on that. I think once we've actually got that working reasonably well, then we'd be looking to implement it on hardware of our own. A big challenge we've had is a lot of the research wearables still don't really allow you to implement your own algorithms back onto them. They'll just collect the data and give you the data, but actually doing something with that in real time is something that it's still a bit of a challenge to do. So from our perspective, we'd probably end up having to develop our own hardware, which would be a process in and of itself.
Yeah, no, absolutely. And I mean, the other bit that is a real education to me in your presentation was a bit about how you can really assess the certainty of the AI, you know, logarithms, I guess, in terms of their decision making, and you know how sure they are, and how that improves your clinical confidence in the decision. So yeah, thinking about fields of extending that from neonatal ICU to other areas, you know, endless potential.
Yeah, and I think that that's something that's really important, because a lot of people don't realize that AI is not like 100% confident one way or another, because when you know, type something into ChatGPT or you use some other tool, it just gives you the answer. It doesn't say, oh yeah, I'm completely sure about this list of symptoms I've just given you. It just says, yep, this is it, job done. Even though it doesn't necessarily have that level of confidence under the hood.
Who are you working with in ICU here?
I'm working with Yoga Kandasamy.
Yeah. And Sue would probably be quite interested too. Sue Ireland is one of his colleagues.
Yeah, that name's come up as well. Yeah, so there's a group of us. I think some of the JCU researchers are potentially going to be involved as well. I think Sonia Brennan and Donna Rudd were both names that have come up in that conversation too.
Yeah, great. And likewise, like I guess Finley linking up with some of the renal physicians, you know, which we can help with might be good for pilot testing the app, and there will be, you know, I suspect quite a lot of just wording changes in terms of how people in the community talk about some of these things and how you find it written in other areas. So, you know, it's the same concepts, it's just slight changes in wording. But look, I think we're just about out of time. If there's no
I'll just quickly pipe in.
It's
it's Kat from I'm in Mackay at the moment, but my substantive is Townsville, with a background in neonatology. So obviously love everything that Stephanie did, and you know, the support that Niku always gives for research is fantastic. And anything to do with saving babies is always positive. I'm just doing a review on auditing medications in IMR for neonates in the special care nursery in Mackay. So like I love that area. But then I also did a 6-month stint out in Longreach last year, and I know that as clinicians rotate, you know, newly registered clinicians rotate into these rural areas where support is quite hard to come, you know, get, because everyone's so busy and people are stretched. Apps that make people's lives easy to try and make not a clinical decision, but support their clinical decisions are well utilized and well accepted definitely in those areas. So from Finley, thank you. That's like a great, you know, interesting, you know, new development that I didn't know was happening. So yeah, great talks for both of you. I really enjoyed them.
fantastic. So look, people have had to peel off, but there are lots of really positive comments in the chat as well. Enormous thanks to Stephanie and Finley for coming in and presenting, and look forward to seeing you next time, where I'll gratefully hand back to Ray to chair again. But thank you very much, and yeah, look, it really is a developing space. This space, and the more conversation we can get between health people and IT and Internet of Things people, the better. So thanks.
Thank you for having us.
Yeah, no worries. Thanks very much. See you.
Yeah.
Bye.